Hey everyone, welcome to Neonatal CSE Review. We're going to discuss a 42-week gestational age newborn today. We're going to start out with a birth weight of 3,500 grams with meconium in the oropharynx. So we know this is more typical with the newborns that are born at 42 weeks, as 40 weeks is normal gestational age at birth, and anything over 38 is okay. So we know that they're more at risk for meconium aspiration if they stay in the birth canal or in utero longer than they should. The heart rate's 160. We've got normal muscle tone and respiratory effort. So we're going to go ahead and suction the mouth and nose with a bulb syringe and clear the airway. We're going to proceed to dry the infant and stimulate them, and then we're going to take them on to the NICU. We're going to place the baby on a 30% oxy hood. The clinical status, the CSE is telling us, is deteriorating, so we've got to act quick. We've got an increase in respiratory distress. Our ABG shows a pH of 7.31, a PCO2 of 42, and a PO2 of 46, a bicarb of negative 18, and a SPO2 of 78%. So we know by looking at the ABG that we've got some critical values of our ventilation status, which is reflected by our PCO2. We have a PCO2 of 42, which is okay, but our critical status is our PO2, which is only 46, and our saturation is only 78%. So our number one critical value is ventilation. It's okay, but our second critical value is oxygenation, which is only 46, and our stats only 78. So we've got to do something to correct that. Our Silverman score is 10. We know that the lower the Silverman score, the better. Our heart rate's 160. Our respiratory rate is 72. So while they do breathe faster than the typical adult, 72 is too high. Blood pressure is 52 over 29. Our breath sounds give us an audible respiratory grunt. So babe is trying to create some PEEP or CPAP in order to help with the shortness of breath and dyspnea. So we're going to go ahead and recommend to the doctor that we initiate a CPAP of 6 centimeters of water and a FiO2 of 40%. We know that our initial CPAP range, we should stay between 5 and 8, so that's typical. We need to use the CPAP to increase the alveolar stabilization and stent the airway open, and then the 40% FiO2 is supplemental O2 to help with that low PO2 and saturation. The FiO2, we're going to go ahead and after the baby is reassessed, we're going to have to increase the FiO2 to 80% to maintain a decent saturation. The CPAP remains on 6. Our baby's agitated. Audible grunt remains. The heart rate's 160. The respiratory rate still 72. Our ABG now is 7.25 pH. A PCO2 of 50. So as you can see, we're starting to go into acidosis. So now our critical value, our prioritized number one critical value is our PCO2, and it has increased to an abnormal number of 50. Our pH is low, showing acidosis. Our PO2 is 44, so we're still extremely hypoxemic. Our bicarb's negative 18, and our saturation 77%. So we've got respiratory acidosis with hypoxemia. The resident asked for a more aggressive treatment. We got to do something quick, so we recommend that we intubate and provide positive pressure ventilation. Our initial settings we're going to recommend is a pressure control SIMV with a PIP of 30, a respiratory rate of 40, a flow of 10, and an I time of 0.5. Our FiO2, we're going to remain at 80%, and we've got our PEEP set at 6. 2 hours later, we're called and the baby is deteriorating, and we've given dopamine to support the blood pressure of 60/40. Our ABG is 7.10, so babe is becoming more acidotic. PCO2 has climbed up farther to 65. The PO2 is dropped to 34. The bicarb is -18, and the saturation is only 75%. So we've got a serious issue that we have got to do our best to correct. The preductal saturation is 91%, and the postductal saturation is 74. So we know that's a huge difference. The x-ray shows flattened ribs and diaphragm, but there's no pneumothorax. If we get an an echo, it shows a PDA, patent ductus arteriosus, so that has not closed during delivery. We're going to go ahead and start an inhaled nitric oxide at 20 parts per million, and there's still no change. What can we recommend at this point? We're going to have to go to our next tool, which is to initiate high-frequency ventilation, and we're going to also continue the nitric oxide. The high-frequency oscillating ventilation is good for poor compliance. We've already tried conventional ventilation, and most protocols definitely call for that first, but it was not successful. We can also try ECMO. It can be used to treat MAS, but it is more of a last resort. So the high-frequency oscillating ventilation and the nitric oxide is administered, and that is linked to greater improvement in oxygenation in severe Meconium aspiration syndrome and PPHN. So the CSE ends there. We hope that the baby is corrected. The ABG should improve. Just a few notes on decreasing the PCO2 on high-frequency ventilation. To increase alveolar ventilation, you could decrease the frequency and increase the amplitude or the I time. Always make small adjustments. A small decrease in frequency is the best option, which will increase alveolar ventilation and decrease PCO2. Increasing the amplitude or the I time affects the size of the oscillations, which will increase alveolar ventilation, but it'll also increase barotrauma. So you have to make sure that you stay at a balance. Increase in I time percent should not be done. Increasing the mean airway pressure would increase barotrauma as well, so don't choose that. Changing the mode definitely don't work, so don't concentrate on trying to do that during a simulation like this. And also to review the general vent settings for an infant ventilator setup. To keep in mind is the PIP should be between 20 and 30. The tidal volume should be between 4 and 6. The respiratory rate should be between 30 and 40 breaths per minute. The FiO2 should be between 40 and 60, or the current FiO2, and the PEEP should be between 4 and 7. The I time should be 0.5 seconds if they have meconium aspiration syndrome. Okay, and remember that your initial nitric oxide is set at 20 parts per million, and you can increase from there as needed, and that is to improve your pulmonary hypertension. Okay, so clearing out the meconium aspiration particulate is going to be definitely is very, very important, and stabilizing the child and helping stabilize the blood gas is going to be your number one goal. Using ventilation, oxygenation as your priorities. Okay, so thanks for joining us. Just click subscribe below so you'll get a notification when we post new sim reviews, and you have a great day.